Hello and welcome to this channel. My name is Jesper, and in this video I'm going to be talking about hyperbilirubinemia in newborns. You might have heard the term jaundice and icterus. These are both terms that describe the manifestations of hyperbilirubinemia, or more specifically, they describe the yellow discoloration of the skin and mucous membrane. Even the eyes of patients with too high levels of bilirubin will be affected and get a yellow discoloration. So hyperbilirubinemia is something that can be quite easy to spot, and especially if it is severe. So what is bilirubin? Bilirubin is a waste product that comes mainly from the breakdown of red blood cells and hemoglobin. I have a separate video on the metabolism of bilirubin that describes the physiological aspect of it. You can find that video on our channel. It's called Bilirubin Metabolism. If you want, you can look at that one first because it might make it easier to understand the rest of this video. Now, in newborns, high levels of bilirubin is something that is seen quite often, and that is why it is important to know if we are dealing with physiological jaundice, which is not dangerous and resolves on its own, or if it is pathological, which is a serious condition and if not properly treated can be very dangerous. We should also note that there are different forms of bilirubin. It's important to measure the different forms and not only the total bilirubin when we're doing lab tests. What form of bilirubin is heightened can give us a good indicator of where the problem is arising. And also, it is important for finding out if we are dealing with physiological or pathological jaundice. Physiological jaundice starts about 24 hours after birth. Then, within 2 weeks, it will improve, and after 2 weeks, it should be clinically undetectable. So it should resolve within 2 weeks. The levels of total bilirubin should not be more than 15 milligram per deciliter in total. The daily levels of bilirubin should not rise more than 5 milligram per deciliter each day. These are criteria that we must fulfill to categorize it as physiological. Physiological jaundice is very common in newborn, which is a good thing because it will resolve itself within 2 weeks when it is physiological. We distinguish between unconjugated or conjugated bilirubin. Now again, I talked about this in more details in the separate video on bilirubin metabolism. But what we need to know and recap is that unconjugated bilirubin is the form that is also known as indirect bilirubin, and this form is lipophilic, meaning it is lipid soluble. And then there is the conjugated bilirubin, and the conjugated bilirubin is the version that has been bound to glucuronic acid. This binding makes it more water soluble. Conjugated bilirubin is also called direct bilirubin, and the process where it is conjugated is in the liver. Important to note is that in newborns with jaundice and hyperbilirubinemia, if we see on a lab test that the conjugated bilirubin is high, then this is a big red flag, since virtually all types of conjugated bilirubinemia in newborns is considered pathological. On the other hand, high levels of unconjugated bilirubin in newborn may often be seen in physiological neonatal jaundice and is not necessarily of any concern. However, it can be. So high levels of unconjugated bilirubin may or may not be pathological, but high levels of conjugated bilirubin is definitely pathological and require further investigation. Now, as always in medicine, there may be exception to these rules, but for the sake of generalization, I memorize it like this. Conjugated bilirubin is a big red flag in newborns, while unconjugated may or may not be. Now, let's talk about some of the reasons for neonates to develop physiological jaundice. So these conditions that we will mention shortly now is going to cause elevation in the indirect, aka unconjugated bilirubin, and these are normal processes. First off, infants may have enhanced bilirubin production due to factors such as large red blood cell mass. Also, the shortened lifespan of erythrocytes is important. Actually, in adults, red blood cells live around 120 days, but in neonates, they only live around 60 to 90 days. And that means that there's a higher turnover of red blood cells, which means more breakdown of hemoglobin and subsequently more bilirubin. Another thing is that the concentration of albumin is lower in newborns. And you might remember that albumin is the protein that transports the unconjugated bilirubin to the liver for them to be conjugated. The liver also conjugates bilirubin in a slower rate in newborn than it does in adults. Now we will talk about a form of jaundice seen in newborn known as breastfeeding jaundice. This is its own type of neonatal jaundice and is due to insufficient or irregular breast milk intake. It is also called suboptimal intake jaundice, and it usually starts in the first week of life. And most often it is because the breastfeeding routine is not yet properly established. The jaundice comes from increased reabsorption of bilirubin from the intestines due to irregular consumption of the breast milk. Treatment is focused on improving the feeding conditions and the intervals, and then phototherapy of the baby might be done. You might have heard the term phototherapy for treatment for jaundice, and this is a method where the baby is exposed to blue light in the spectrum of 460 to 490 nanometer wavelengths. This is a type of blue light that isomerizes the bilirubin, and essentially it makes it easier for the baby to excrete the bilirubin after it's been isomerized by the blue light. It is generally safe and effective. The next form we will talk about is breast milk jaundice. It is again its own type, and we should not mix it with breastfeeding jaundice. So breastfeeding jaundice was the one we talked about before, and now we will talk about breast milk jaundice. They sound similar and it's an easy mix. Believe me, I have mixed the two of them. However, in breast milk jaundice, the reason why the baby develops jaundice is components in the milk itself. To be exact, it is due to an increase in beta-glucuronidase. Beta-glucuronidase is a compound that may lead to increased reabsorption and deconjugation of the bilirubin, and therefore it is harder for the baby to excrete the bilirubin normally. The treatment is done by supplementing the breast milk with a breast milk formula which do not contain this compound, and if needed, phototherapy can be done as well. Moving on in this video, we will talk about potentially serious causes and several life-threatening conditions causing jaundice. But remember, just because something can be due to a serious illness or underlying condition does not mean it is. So bear in mind that many of these next diseases are rare. The most common is the most common, so don't panic. Next up, let's talk about pathological neonatal jaundice and causes that cause it. When we think about high levels of conjugated, so direct bilirubin, we associate it in general with hepatocellular disease or cholestatic disease. Hepatocellular is liver cells, and what we mean by cholestasis is that bile is somehow clogged and essentially it is not properly flowing through the liver or the biliary system. Chol for bile and stasis for slow or stagnant. I mentioned in the previous video that the conjugated bilirubin flows together with the bile to the intestines via the biliary tract. So this is why cholestasis also leads to buildup of conjugated bilirubin. Also, when we talk about cholestasis, we categorize it either as intrahepatic or extrahepatic, depending on the level of obstruction and where the bile builds up. We can use ultrasound as a tool for differentiating where the problem is. Let's now talk about some lab values and markers. When we measure the level of conjugated, aka direct bilirubin in a newborn with some sort of pathological jaundice, we can expect the direct bilirubin level to be over 2 mg per deciliter, or over 15% of the total bilirubin. These are red flags. Some other important lab value indicators is gamma-glutamyl transferase, which we refer to as GGT, and alkaline phosphatase, which we refer to as ALP. In cholestasis, there is a rise in the serum levels of GGT. The rise in GGT tends to be higher in extrahepatic disorders, such as biliary atresia. Extrahepatic meaning it's outside or after the liver. In progressive familial intrahepatic cholestasis, which is a type of intrahepatic disorder, the GGT levels are often normal. This is an intrahepatic inherited cholestatic disorder which affects infants and young children. In the patients with progressive familial intrahepatic cholestasis, the liver cells are not able to secrete bile properly, and therefore the bile builds up in the liver cells and damages them. AST and ALT are lab markers that are liver transaminases. They might be elevated in conditions like hepatitis, alpha-1 antitrypsin deficiency, and in general when there is hepatocyte damage. Hepatocytes are the main cells of the liver. Alkaline phosphatase is another lab value which indicates liver or bone damage, and it especially makes us think about potential disorders with cholestasis. One example causing cholestasis is biliary atresia. Biliary atresia causes extrahepatic cholestasis. This is a serious condition where the bile ducts that carry bile from the liver to the gallbladder do not develop. This may severely damage the liver and should be diagnosed as early as possible. An operative treatment called the Kasai procedure can be done. The Kasai procedure is a surgery where there will be made a bypass connection between the liver and the small intestine so that the bile can properly flow out of the liver directly into the intestines. This procedure is more likely to be successful when it is done before the infant is 2 months old. The patients may also need a liver transplant. Let's talk about some other diseases that cause intrahepatic pathologies causing jaundice. We won't go into too deep details for each disorder or disease because there are very many. Also, this is not a complete list. The differential list is vast, so it's hard to cover absolutely all diseases that can cause hyperbilirubinemia. Certain hereditary genetic disorders may lead to cholestatic disease. We will shortly mention a few. Cystic fibrosis is an example of a genetic inherited disorder, and in order to get cystic fibrosis, both biological parents must have a mutated CFTR gene, either as a carrier or themselves having the disorder. It's inherited autosomal recessively. The cells have a problem with the chloride transport in cystic fibrosis, and as a result, fluids such as sweat, mucus, but also bile can become unusually sticky and thick. This can irritate the ducts and itself reduces the ability for flow. Cystic fibrosis affects many other organ systems, especially the lungs and the GI tract. Alagille syndrome is another genetic disorder that can be inherited, but also the mutation that takes place can occur sporadically, meaning it is not inherited from a parent but rather happens or occurs sporadically. In Alagille syndrome, bile ducts can be affected in several ways. They may be too few, too narrow, or abnormally shaped. This again makes the bile build up in the liver and causes scarring and liver damage. Alagille syndrome also affects other organ systems, especially the heart, and the patients can have facial features hallmarking the disease. Such facial features hallmarking Alagille syndrome are, for example, a broad forehead, a pointed chin, and eyes that are deep sunken. Alpha-1 antitrypsin deficiency. This is an inherited disorder which mainly affects individuals with European ancestry. 1 in 1,500 in this population may have the disorder. So unlike many of the other disorders we talk about in this video, alpha-1 antitrypsin deficiency is relatively common, so to speak. The patients with this disorder have low levels of the protein alpha-1 antitrypsin. It's also usually referred to as A1AT. In our body, there are enzymes that are breaking down other products. An example is proteases. They break down proteins. The A1AT protein normally inactivates excessive function of proteases, especially elastase. So in patients with a deficiency of alpha-1 antitrypsin, there will be less inactivation of elastase, and less inactivation leads to activation, right? So basically there will be too much breakdown of proteins, especially in the lungs, since A1AT is not there to regulate its activity. Breakdown of too much elastin in the lungs can lead to lung disorders like COPD, emphysema, chronic bronchitis, and bronchiectasis. Liver problems is another major complication of the disorder, and especially infants can manifest with jaundice, and even sometimes liver failure. Sometimes a liver transplant may be needed. However, many people live with this disorder without having many symptoms. It is especially important for people with these disorders to not start smoking. Now let's talk about some metabolic disorders that may cause jaundice in infants. There are many, so we will categorize them and mention them. So for disorders of carbohydrate metabolism, I would like to mention galactosemia and fructosemia. In galactosemia, the newborn has an inherited disorder that affects the ability to convert galactose into glucose, therefore galactosemia. It's important that these patients do not consume milk with lactose and receive special soy formulas instead. Fructosemia is also a rare inherited disorder, which is due to a mutation in the gene encoding for aldolase B. This leads to them not properly being able to break down fructose. And fructose can build up in the liver and even cause liver failure. Also, in this metabolic disease, we aim to remove as much fructose and sucrose from the diet as possible. Moving on, let's mention some disorders of lipid metabolism that may cause jaundice in newborns. We'll start with Gaucher disease. Gaucher disease is an inherited lysosomal storage disorder, and these patients have a deficiency of an enzyme called glucocerebrosidase. Without this enzyme, there is accumulation of lipids like the glycolipid glucocerebroside, and the accumulation especially affects the liver, the spleen, and even the bone marrow. The age at presentation varies between individuals. Also, the severity of the disease varies. There are three major types of Gaucher disease. Type 1 is non-neuropathic, meaning it does not involve the central nervous system. Patients usually present with hepatosplenomegaly, so enlarged spleen and liver, anemia, thrombocytopenia, and therefore poor blood clotting. There is also tendency for the skeletal system to be affected. Type 2 is a neuropathic type, and this means that the central nervous system can be affected. Glucocerebroside can accumulate in the brain. Type 2 mainly presents in infants and in newborns. It is characterized by various motor deficits like spasticity, muscle weakness, and difficulty in swallowing. Also, in this type, patients may have skin manifestations, organomegalies, particularly the spleen, anemia, and thrombocytopenia. Thrombocytopenia is a low number of platelets. Gaucher type 3. This is also a form of neuropathic glucocerebroside accumulation. However, it develops slower than type 2. It is often referred to as chronic neuropathic Gaucher disease. Some key features of the neurological complaints, aside from the ones discussed for type 2, is horizontal gaze palsy, meaning they have problems moving their eyes from side to side, myoclonic seizures, which is a form of muscle spasms coming in shockwave patterns. Also, these patients may present with pulmonary interstitial disease. The prognosis is varying, but some may have a very good prognosis, living full lives. Neiman Peak disease. This disorder is characterized by not being able to degrade sphingolipids, which are types of fats within the cell membrane. It is also separated into three groups or different diseases: type A, B, and C. A is the most severe form of Neiman Peak disease and is manifesting early in infancy. It has a poor prognosis, unfortunately. It is caused by mutations in the SMPD1 gene. Type B starts showing symptoms later, usually in pre-teen years. The gene affected here is also the SMPD1 gene. The prognosis of type B is better than in type A. Type C is associated with mutations in other genes, in NPC1 and NPC2 genes. The range of when the clinical manifestations presents for type C is quite large, and symptoms may present in neonates, in infants, preteen, or even in adolescents. However, in adults is rare, and it usually presents in younger children. Next we will talk about Wolman disease. What we need to know is that this is an inherited disorder in which affected individuals have a deficiency of the LAL enzyme, the lysosomal acid lipase enzyme. And because of this, they cannot break down lipids, so fats essentially, and it can lead to some serious signs and symptoms such as enlarged spleen and liver, ascites, abdominal distension, vomiting, and more. This is a very serious disease which unfortunately has a very bad prognosis. Luckily, it is very rare. There are genetic tests available for the affected gene. I will mention one last metabolic disorder, which is one of amino acid metabolism, and it's called tyrosinemia type 1. Here, the affected individuals lack an enzyme called fumaryl acetoacetate hydrolase, or FAH for short. Because of the deficiency of this enzyme, the patients cannot break down the amino acid tyrosine properly. This leads to buildup of tyrosine and its metabolites, especially in the liver. It may also accumulate and cause damage to the kidneys and even the central nervous system. The manifestations appears early in the first months of life, and they include failure of weight gain and growth, jaundice, vomiting, diarrhea, fever, and an enlarged liver. A diet low in tyrosine is important for the therapy, together with a drug called nitisinone. Nitisinone is a rather new drug. It helps to prevent the buildup of toxic metabolites. With proper diagnosis and treatment, the prognosis is good. However, in the acute form, children may need liver transplantation. Next, we can talk about neonatal hepatitis. This is inflammation of the liver, and it presents in neonates early in infancy. Usually a virus is the causative agent. Sometimes the virus can be acquired vertically. What this means is from the mother before birth. Some typical viruses that may cause this is cytomegalovirus, Coxsackie virus, rubella, which is also known as German measles, and the hepatitis viruses A, B, and C. In the case of hepatitis B and C, it may lead to chronic liver disease, but if hepatitis A is the culprit, the disease usually resolves by itself within half a year. Bacteria may also in rare cases cause hepatitis in infants. Also, systemic illness from bacteria such as sepsis may lead to liver damage or even other organ damages. Also, parasites can be a cause. An example is toxoplasmosis. That brings me on to the torch infections. Torch infections is an umbrella term or an acronym used to remember certain diseases that can be spread before birth, during birth, or after birth from the mother to the baby. T stands for the parasitic disease toxoplasmosis. O stands for others, meaning several diseases like syphilis, varicella zoster, listeria, and parvovirus. R stands for rubella, which was the German measles. C stands for cytomegalovirus, and H stands for herpes simplex virus. So TORCH is an acronym for these diseases that can be spread from the mother to the infant. Next, we will talk about endocrine disorders affecting hormones. And this is also a cause we need to consider. An example such as hypopituitarism, when the pituitary gland fails to produce its hormones or produces too little of them. Also, hypothyroidism may severely affect infants, and this is when the thyroid gland produces too little tyrosine, which is a thyroid hormone that is responsible for stimulating our metabolism. So both hypopituitarism and hypothyroidism are endocrine disorders which may also cause jaundice or hyperbilirubinemia. Of course, also defects or abnormalities in the anatomy of the individual may be an etiological factor for jaundice. An example is ductal plate malformations. These are a group of congenital liver diseases categorized by fibrosis of the liver tissue. The ductal plate is the structure in embryology that gives rise to intrahepatic bile ducts. Another example is Caroli disease, which is categorized by cystic dilations of the intrahepatic ducts. The bile ducts is essentially wider in patients with this genetic condition. So far, we did not really talk about pathological versions of unconjugated hyperbilirubinemia or hemolytic diseases. I will do that in a later video, so you can find that under hemolytic disease of the newborn. Thank you so much for watching this video, and I hope you liked it. If you want to see more of these videos, please press the subscribe button, and I hope to see you in another video.